Brad Rund. I am a nurse practitioner from Indiana. Work at major hospital. It's not a major hospital. It's a rural hospital. Okay, everybody gets that confused, so I make sure to clarify that. But I'm a multi-specialty NP, and what I do is basically they saw the fact that I was an ER nurse, and ER nurses are kind of specialized in everything, right? So they kind of put me in a role that I'm more like a float NP, so I go to urgent cares, cardiology, a little bit of everywhere, wherever basically they need me for the day. Lets me be pretty versed and is pretty great, I think. So one of the things that I do with all my lectures is I like to make sure that everybody has resources or something, to take back that's a tool. So there will be some QR codes throughout here. But one thing I want to pass around that you guys can all look at, this is something that I keep at my desk, and it has been an awesome, awesome tool. There's a pediatric version, and there's an adult version, okay? Cannot commercially support anything, but I want you guys to kind of take a look at it and pass it around. It's great because it has pictures on one side, and then the back side of it will say clinical features, dosing, and all of that, okay? So I'll pass that around. All right, everybody's here for dermatology, right? Everybody loves rashes? Yeah? I mean, you guys made it back from lunch, so I'm super excited nobody went and took a nap, unless that's your plan here. So we're gonna recognize some commonly seen pediatric derm presentations, not only in the ER, but urgent care as well. Outline the methods and tools used to diagnose conditions. Role of history taking, physical exam, use of diagnostic test referrals, identify pharmacological agents, common. So this is, if anybody didn't meet him in my other presentation, this is my son Everett, okay? A little bit of statistics for you is dermatological complaints in the emergency room is actually pretty low as recorded. It's actually at 3.3% of ER visits. But when you broaden that out, it's actually 10% of pediatric ED visits are dermatological related, okay? The problem is we don't know if that statistic is actually accurate because a lot of times there isn't always a complaint for that, okay? As far as when you do your triage and stuff, it's not always a complaint, a skin complaint, any of that. But you also look at people that come in with fever. Fever typically has a rash, but it's documented as fever. So we think it's a little bit higher than what it is. Little review of the anatomy of the skin, okay? Remember, it's a network of cells. Epidermis, dermis, subcutaneous, and muscle layers. So stick with me for a second on this. Because this is how I explain it to parents, and I want to make sure that it gives you guys kind of a basis to understand as well. And I have to use my hands, sorry. So ball pits. We've all been to like Chuck E. Cheese or something like that, has ball pits, correct? So think of those as the cells. There's gaps in between them, and as we get lower and lower in there, those balls get a little bit harder to move, right? So it gets a little bit compacted down. So I explained to him that, whether, and it's gross, kid pukes in the ball pit. That kind of drips down inside there and gets infected, correct? So looking at that and explaining the difference in infections and the way that goes that's how I explain that goes inside there. So think of it kind of like as a ball pit. Kind of good analogy for you guys? You what?
I'll never go in one ever again.
Yeah, never go in a ball pit. Okay? All right, so these are actually my two sons now. I usually have just Everett up there, but Liam as well. He's my older one. Whenever we're doing assessments on kids, it's really important as clinicians is making sure to do a good physical assessment, okay? Remember that we have parents across the spectrum here. We've got parents that are super protective and tell you every single detail, like crazy, and then we have some that are like, oh, my kid's sick, I don't know. That's all they give you. Well, is it right? I mean, so you really have to do a physical assessment because some of these kids can't talk and can't tell you what it is. I worked EMS I'm still in EMS. I'm a full-time firefighter, NP as well. But we do have a children's nursing home there, and sometimes I'll go in there and the nurse will be like, well, I don't know what's wrong with them. And I was like, well, have you done an assessment? No, not really. And then like I start developing into the assessment, I'm like, oh, this kid's been sick for a little bit of time. But make sure that you're getting in there and doing a really good assessment. The one thing about dermatology assessment is looking at your skin types too and being familiar with those, because different skin types have different presentations, okay? And that may be just me being an overprotective parent too, but I just make sure that everybody gets a full assessment. Babies, no matter what, no matter how they present in your ER, if they are like had a fever and you have a known complaint, you still better do a full assessment, because pediatrics is going to be a high area for possibility of lawsuits, okay? You mess with a kid, that parent's coming at you, okay? One thing I want to point out about the assessments as well is, so I had a kid come in, third visit in 24 hours, fussy kid. And I'm like, something's not right here. And the parent's like, he has an ear infection. We didn't pick up the antibiotics, but I just know he has an ear infection. That's what he was diagnosed with. Look at the ears. Ears are red, okay? So I get it, ears are red, but ears turn red from just screaming, correct? So agitated kid, red ears, MP diagnosed with ear infection. No other presentation. Do a full assessment on the kid. I actually found a hair tourniquet. Hair tourniquet on the toe, but since the parent said ear complaint, came in, saw red ears, diagnosed with that. Third visit on why this kid won't. So that's why I encourage full assessments every time. Don't make fun of me, okay? My students and everything made fun of me for a long time. The most important tool you can have in dermatology, to me, is this magnifying glass, okay? We don't get close enough. We don't look at the skin enough. We're like, you got a rash, looks good. Yeah, not really looking at it, okay? But that lighted magnifying glass disappears out of my office now more than anything ever, okay? I even kept it in a locked door and somebody got a key to it. It's like $16 on Amazon, but 100% worth it. Swabs. How often do you guys swab stuff? A lot? What, not a lot? A lot, okay. If it's a second visit on something, typically I'm swabbing, okay? And that's ear infections. If there's fluid coming out and there's not been any great antibiotic, no great improvement, I'm swabbing that ear and sending it. I've caught some weird stuff in there that Augmentin wasn't going to treat and needed to switch to like clindamycin or something. Don't be afraid to swab it if need be. CBC, SEDRA, consider CMP, thyroid. We talked about thyroid earlier in this room. Iron for vasculitis cases, okay? What's your most expected imaging for dermatology that you think you're going to order? Ultrasound. Ultrasound. Foreign bodies, abscesses, any of those. X-ray, CT, if systemic is concerned, or also looking at that secondary complaint of dermatitis, okay? Just because they have a rash doesn't mean that rash is skin related. Consider that, okay? Just because they have a rash doesn't mean it's skin related. Documentation. This little guide, it is something you can pull off the internet. Just Google it real quick. And making sure you're documenting, okay? Look at this chart, compare it to your documentation, because you may not be treating this right away. It may be that, hey, they're stable, we're gonna refer you to dermatology, refer you back to primary care, but documentation is gonna help that next provider in their progress, okay? I won't go too much into each of these. Make sure that you're documenting the morphology, demarcation, colors, secondary morphology. Secondary morphology is like dry crust, fissures, erosions, ulcerations, scaling, Distribution as well. Where exactly is it located? Can you guys load images into your charts? Yes. Make sure that you do that, okay? If you don't know how, make a friend in IT and figure out how, because it is awesome. I'm interactive, sorry. If you guys didn't want to talk after lunch, too bad. What do you guys think this is? Okay, tell me what you're seeing. Okay? Nose, lips, pretty common. This website right here, by the way, you guys can see that, is an awesome resource, okay? It's not a US-based resource, it's New Zealand, but it's really good. What about this? This is impetigo, exactly. It is a form of impetigo, okay? I know. It's kind of gross, but this is something that I commonly see in urgent care with pediatrics right now because teenage boys are gross. They are gross. And what do they have right now? The long hair, the mullets, the greasiness, the failure to want to clean and put deodorant on. And you're getting these infections in here. You can find infections back in here commonly as well too. This is being diagnosed because providers don't get in there and look at it as dandruff and eczema. Okay? This one is a little bit more clear of a picture, but actually getting down in there and looking in that scalp is super important. Okay? Can also look like cradle cap. So tell me the difference here. Bolus versus non-bolus.
Bolus is caused by staph. They got those big rounded. It almost looks like a cigarette burn.
Okay. Almost looks like a cigarette burn. The honey crust is what was super important. I think somebody said honey crust, didn't they?
Yes. Yeah.
The honey crust appearance, exactly, with impetigo. What is our common pathogen? Staph. Staph, but it can also be strep, or it can be a combination of staph and strep. You can get multiple things in there because what do the kids do? They itch. They itch, they put fingers everywhere on their body, okay? I never realized how gross this really is to discuss after lunch, I'm sorry. But they itch everywhere, okay. Yeah, ecthyma. What is ecthyma? Ulcerations, okay? Ulcerations. Make sure you look, this will be when we talk about treatment here in a little bit, make sure you're looking at these kids, not only the outside, mouth, nose, rear end, and genitalia, your full assessment. Now, I understand that it's weird for an adolescent to do that, but ask them directly. Is this anywhere else? Do you have it in your male portion, your female portion? Do you have it? Because they're transferring this bacteria everywhere. So this goes into that consideration. Do you do systemic or isolated? Okay. Most likely, if it's around the nose, we've also probably got it in the nose. Okay. Treatment plans. What do you guys want to treat with? Bactroban, okay? It's your first line. AAP guidelines is TID for 5 days. Make sure that you're watching on that nose though, okay? Are we putting it inside the nose? You can put it inside the nose, just on the inside, and that's completely fine if need be. Systemic, we're looking at Keflex. The oral is 25 to 50 milligrams per kilogram per day, divided every 6 to 8 hours, and duration is 7 days, okay? With that, dosing in kids, How do you dose kids? Do you dose them every 6 or every 8 hours on the medicines? You guys know? So the range is 6 to 8, but think about their school, okay? They'll give it in school, but they've got to give all these permissions and all that stuff. So whenever you're dosing kids' medications, consider the fact, do they have to take this at school? It's easier for them to say, take it in the morning, take it when you get home from school, and then take it before bed, okay? If you increase it to every 6 hours, your compliance rate declines substantially. Bactrim, 8 to 12 milligrams per kilogram per day, divided every 12 hours for 7 days. This can be a shorter course as well if need be. That is an option if you have a person that's non-compliant. Make sure you kind of read your audience, read your parent and how compliant they are going to be with this, okay? Because a majority of parents, they will start great with medication and then they just taper off real quickly. So if you're doing long-term medications, it probably is not going to be the best. Isolation, make sure to isolate them from school. Be very blunt with your teenage boys and be like, look, wash your hair. You're gross, wash your hair, okay? I mean, I've had to tell kids that in peds before. I'm like, dude, I'm sorry, but you smell. You've got to clean yourself because you're going to end up with infections, okay? I had to do that with an adult in the ED and actually took them to take a shower because otherwise, and if we have homeless people, that's kind of an option, okay? Is, hey, can we give them a shower real quick as a nurse advocating for your patient because they're going to have increased risk of infections. What about this? This is ringworm. Ringworm. It is ringworm. Yep. So there can be the presence of multiple dermatophyte infections, but it's not really common. You can always KOH prep if in doubt. Fluconazole, 6 milligrams per kilogram once weekly, oral versus topical. Remember, if you're going to do a topical medication with a kid, how is it going to make them appear? Because that's going to affect their compliance. We see people that want to put creams and do creams with kids. They're not going to be compliant with it because it makes their face look greasy or it makes their hair look greasy. Same kind of thing there. Okay. Impetigo, we talked about this earlier. This can progress, right? Has anybody seen this?
Yes.
Yeah. It's pretty bad, isn't it? So a staph infection can progress very quickly in kids. Remember, your skin, your network of cells, I got to use my adult term and that wouldn't be appropriate. Your network of cells kind of expands out. These get to the capillaries, it starts expanding very quickly. You can see a progression sometimes within hours to hypotension. And these kids really need admission or infectious disease consults, okay? Do you guys have pretty good infectious disease around here? Kind of? Yeah. Expect full workup and cultures as well. These kids get burn management, okay? Consult with your burn team as well and let them know. They do need fluids. They need to prevent hypovolemia. Pain management is super important. Antibiotics, the loss of skin integrity, and wound care. So I'm usually calling burn, and I'm also calling a wound care nurse as well if they're not together in the same place. Make sure you're doing emollients and non-adherent dressings and prevent that heat loss. Here is your antibiotic selection. Typically, what I've seen is they almost always just say Vanc, okay? Vanc, 45 milligrams per kilogram per day, divided doses every 8 hours, okay? Weight-based dosing does change for neonates as well. This is another commonly misdiagnosed thing. What are you going to be asking your patient during this? What was it?
Get into contact with anything new.
Okay, contact with anything new, any new medications, violence. This is adverse drug reaction, okay? It is doxycycline phototoxicity, okay? Doxy, whenever patients are prescribed doxy, we always lack that education on making sure they stay out of the sun, okay? Spring break, I feel like I see this a couple times afterwards because we prescribe doxy for acne, and then they come in with this complaint. They're like, this is a horrible sunburn. I don't know what happened. I thought I put sunscreen on. And you're like, well, it doesn't really matter. That's not what it is. It's the fact that doxycycline, okay? What are you guys seeing doxycycline also prescribed for here in New York? Lyme disease. So you're seeing an upward trend of Lyme disease. I read that in the sign in the park that you guys are having a little tick issue. But doxycycline is becoming prescribed for that, which is then resulting in this. Make sure that you're educating your patients on this. If you're prescribing doxycycline for any type of skin infection, document in there, prescribe or discuss safety of medications, okay? If you don't have a simple text you put in with that, probably a good idea.
Is that resolved?
Yes. So typical treatment for it is stop the antibiotic, avoid the sun, steroids. Depending on the grade of what it is, you can do topical, oral, or IM. Prednisone taper based on weight, and then you can do IM if it's really bad. There is some conflicting stuff, and I'm sure that you've seen it in regards to steroid, whether or not we do taper versus burst and all that. I'm gonna let you do your own research on that and form your own opinion because it seems to be a big conflicting thing. Even in like asthma treatment and all of that, there's some discrepancies in it. What was that? Dress syndrome. Dress syndrome. It is commonly confused as viral. This is a viral reaction, okay? Because it kind of gets that appearance of sometimes you get the amoxicillin rashes, those that come in and they're like, I don't really know. So there are some key differences here between adults with kids. Well, adults typically don't have facial edema or facial involvement. Peds do. Pediatric patients do. The common drug triggers are anti-epileptics, antibiotics, Bactrim. Bactrim is a main one with this. So we prescribe it for different skin, UTIs, and this is something they kind of develop. So if you suspect this, we're going to check labs, CBC, liver functions, creatinine, urinalysis, and then it's important that they're getting follow-up with this. They need thyroid testing, then 3 months and 6 months. Okay? Treatment can include steroids with a long taper, cyclosporin, 5 milligrams per kilogram, divided twice daily for 2 weeks. And then, did anybody attend Mary's lecture yesterday? IVIG can also be given for this. What do we think? Dress? What? Viral. Amoxicillin reaction. It's really important to get that history. It's measles. Measles, yep. So something else to kind of consider here, okay? Look at the measles presentation across the skin. The skin colors. So you probably, on the dark skin, touch it and you're just gonna kind of feel a little bit of texture. It may not have that true red appearance with it. This image from St. Jude, I believe, and it's just great to be able to see that. And looking at it with the magnifying glass, the upward trend of anti-vaxxers, is kind of the blame for this. But remember to look for the symptoms of cold-like symptoms with runny nose, sneezing, cough, sore red eyes that may be sensitive to light, watery eyes, swollen eyes, high temperature. What else can we look for in the mouth? Exactly, the spots in the mouth. So they're typically white, grayish white spots in the mouth. Aches, pains, loss of appetite, tiredness, irritability, general lack of energy. That's just after lunch for you guys. That's not measles, I promise. Symptomatic care, Tylenol, ibuprofen, fluids. And remember that with any skin condition, light or direct sunlight can make that complaint worse, okay? So I want to hit on measles really quick because it is kind of that upward trend. And right now, the best I could research was you guys have 4 cases within New York, okay? 3 in the city, 1 outside the city. Your last outbreak was in 2019, mainly focused in Rockland County. That's what?
That's right.
Rockland County. Do you guys know why Rockland County was the main target? What is it?
It was a community that didn't vaccinate their children, and somebody came back, I think, from Israel.
Yep.
And brought measles.
Yep.
And it just went right through.
So the last vaccination rate I saw for them was about, and there's Department of Health in here, so I'm hoping I get this right. It was like 54 to 56% of the community is actually vaccinated. So your top 5 counties are Rockland, Yates, Orange, Sullivan, and Jefferson. Okay? And in 2023, the Department of Health for that county came out and basically blamed the Orthodox community and said, this is all because of you guys not being vaccinated. Okay? Probably not the best thing. But, so the rate of transmission, measles, and I really wanted to hit really big on measles, that I had to take more notes. And then the more I learned, the more I was like, oh, I gotta share this. So pardon my little notepad right here. But the rate of transmission, so the flu can transmit 1 to 4 people. So 1 person transmits to 4 people. Smallpox, 1 to 5. Mumps, 1 to 7. Rubella, 1 to 7. Pertussis, 1 to 12. Measles, 1 single person can infect 18 people. So it goes pretty quick throughout the community, okay? 1 in 4 people with measles is typically hospitalized. The hospitalization is not typically related directly to the measles. It's related to the secondary stuff that occurs with it, okay? Remember, just because they have the measles and the rash doesn't mean that they don't have secondary ear infections or pneumonia, which commonly accompany these. Go ahead.
I remember having the measles. I don't remember being obtunded. My mother said it was, and in those days, nobody said, rural people didn't send you to the hospital. And I remember when I woke up, my grandmother picked me up, and the light hurt my eyes so badly.
Mm-hmm.
Because I remember saying in Italian, just take me away from the window.
Yep.
But I was telling my mother I could have been Einstein. I must have lost a lot of IQ points.
When I was like 6, I remember, because I was supposed to start first grade and I didn't get to go to first grade myself.
Right, which I learned, New York, you guys have mandated vaccinations for schooling, is correct? But there's the Amish and the Jewish community are not the best at vaccinations, right? So over the course of the years, the MMR vaccine was estimated to save 1.8 million people. So since that vaccination has really taken effect, it's saved 1.8 million people. The one other thing was, anybody watch the Brady Bunch? It was actually in the Brady Bunch too. Marcia had measles and was so excited that she could stay home because of measles. So it's not that measles is bad, it's the secondary complications that come out of measles that we need to be watching for. Making sure that we have good follow-up because it can affect the brain. It can develop into pneumonia or ear infections as well. What is that? Yeah, contact dermatitis. Oh, I guess I put it up there. Cheaters! So poison ivy or other contact. Use caution because I feel like I see a lot of providers try to do short burst short burst steroids. What happens is we do short burst steroids and we're like, it's not that bad. Just take it for 3 days and then you'll be fine. It comes back with a vengeance, and it's not good. When should we be doing steroids with these? This is the only complaint. Should we be doing steroids? No. No. So typically if you've got it, face involvement, genitalia, multiple site locations is when we're going to be doing steroids. We do have a tendency, especially in urgent care, because we feel that rate of patient satisfaction that comes because we get some little bit of pressure to, well, if we give them steroids, it's going to make it a little bit better, and then we get a better, but that's not always what happens. The suggested dose is generally 7 to 10 days. The other thing is, if this is not related to poison ivy, so if you have contact dermatitis, or allergic dermatitis is basically what I'm going to go to with this. Allergic dermatitis is make sure you're getting your history with that as well. Okay, what has changed? What's going on here? Remember that we're educators, especially in the ED, that we may have to make that suggestion. Stop using that, okay? What you guys think? It's on there again. Dang it. It's down at the bottom. Oh, you guys didn't see it. Yes. Okay. Is this itch usually worse day or night? Night, exactly. Scabies should be part of your differential diagnosis on any itchy rash where there's no cause readily available. It is also possible for eczema patients to acquire scabies. Okay? So they have those breaks in the skin where I've seen patients come in that have eczema, they have really bad skin already, and they have scabies on top of it. It makes it look a whole lot worse. So do a good history taking. Anybody else in the home have it? Anything else going on here? Trunk, limbs are the prominent areas that are affected. Face and scalp rarely have involvement other than infant or bed-bound elderly patients. They may have involvement of the face and the scalp. Generalized rash, erythema, papular urticarial lesions. This is caused by the allergy of the mite. That's what's making them itchy, is the actual response to the allergy to the mite in their waste. So scabies in their poop causes you to be itchy. This can be in the genitalia as well, or in the groin, or in the axilla, and may be persistent for several weeks before they're actually even seen. Okay, so kids may be complaining about this for a while before parents are like, okay, now we'll get you seen, because they just think it might be something they're allergic to, allergies and all of that. What do you see different in this presentation compared to this one? Creases, flexor regions. Linear. What'd you say? Clusters. Okay. This is highly contagious. Remember that. There's also what is called Norwegian scabies.
That sounds exotic.
Yeah, it sounds exotic, doesn't it? Do you guys know what the difference between the Norwegian scabies and the scabies is? So typically this scabies is not crusted. Norwegian scabies has a crust to it, which the crust can kind of have that presentation sometimes of, is this impetigo or not impetigo? Consider your evaluation in it. The crusted scabies, the Norwegian scabies, actually is more contagious because the mite involvement is a lot higher. It's still the same treatment, and it with any of them, you typically see it. You can go into the fingers, the webs, even early involvement. You can have palm and sole involvement on some of them. People automatically think, well, they've got rash on their palms and their feet. It's hand, foot, and mouth. Try to get out of that habit because it's not always hand, foot, and mouth. All right. Here's a great little infographic here. Notice the mosquitoes and hives have a similar presentation. What causes that in our pathology? The histamine response, exactly. So it's going to have very similar presentations to that. Fleas, bed bugs, they don't. They typically have a bite, and that's it. It's not a full histamine response. Okay? A little bit ago, or in my other presentation, I thought I had it in here, but I don't, is clinical pathways. Are you guys familiar with clinical pathways? Yeah, great resource. CHOP is the main one I use, or University of New Mexico. What is the typical first line for any type of ED urticaria that they say is just Zyrtec. A lot of them actually say Zyrtec in triage and then can consider a secondary dose after triage and then discharge home with Zyrtec. So if you don't have a true cause, look at the use of Zyrtec in that and make sure you're educating them on allergies and stuff that's going on. Okay, multiple different causes of skin rashes. Did you guys all have a chance to look at the back there? Really cool resource. Kind of shorter presentation for you guys right after lunch, so that way you guys can get out of here. Okay, if you guys have any questions, feel free to connect with me. Also, if you don't have a dermatologist friend, make one. Because I found a dermatologist that I'm friends with and I'm constantly like, what's this? Send them pictures. They love it.